Bismillahirrahmanirrahim. Okay, this is the next lecture, and it's regarding it's like a continuation of chronic inflammation. So we are going to discuss in detail about tuberculosis and actinomycosis. Okay, so inshallah, in the lecture, after the lecture, you can able to define granuloma and explain the pathogenesis of granulomatous inflammation and interpret the laboratory investigation in diagnosis of tuberculosis infection, and you can define actinomycosis and explain the clinical outcome of actinomycosis in cervicofacial region. So that's why it's important for dental students, because this infection comes in the neck and the face region, cervicofacial region. Okay, now let's go to the lecture. So tuberculosis is an infection which comes most commonly in the lung. From the lung it goes to other parts of the body. So it is called pulmonary. So it is called pulmonary tuberculosis. Okay, so the bacteria responsible for pulmonary tuberculosis is Mycobacterium tuberculosis. This is the bacteria which is responsible. So I told in the last session, the bacteria is present in the air. It is taken to the in the respiration system, and it goes to the lung, right? So there are some mycobacterium bacteria which can present in the milk. It was a big problem 20 years back. Okay, now all the milk are pasteurized. You all know pasteurization. It is all pasteurized and it is all packed. Okay, in those period the people used to take milk directly from the cow and they used to boil and drink. So that if they don't properly boil, this bacteria will not die. So this is a mycobacterium which taken in the milk, so it affects the intestine. It affects the intestine and it affects the oropharynx region. So this mycobacterium is called Mycobacterium bovis. Bovis means cow. Okay, so this is responsible for oropharyngeal and intestinal tuberculosis. Nowadays it is very rare. It is extremely rare. Okay, so and why? Because of pasteurization in the government policy, compulsory pasteurization of milk, they removed this bacterium almost most of the countries. So except in the few village where they drink directly from the cow, so they have this kind of problem. So Mycobacterium tuberculosis is responsible for pulmonary tuberculosis. Mycobacterium bovis is responsible for oropharyngeal and intestinal tuberculosis. See, previously, like before the AIDS, HIV, no Westerners were bothered about, concerned about tuberculosis infection, because this tuberculosis infection is very common in the tropical countries like African, South Asian countries. Understand? So they are not worried about them. So Westerners, they didn't do much research. Most of the research came from these countries. But when the HIV came, they started getting this disease. So now tuberculosis is a big concern for them because they load lot of HIV cases. They have lot of HIV cases. So the TB easily comes in the HIV patient. Tuberculosis infection is commonly called as TB infection. It easily comes in the HIV patient. I will tell you why. Even you can tell why after this lecture. So it is commonly seen in the HIV patient. So that's why now the developed countries also having the problem, because previously it is a problem of developing country due to poverty and overcrowding of people. So in the developed nation, it is a problem of immunocompromisation such as HIV patients. So Mycobacterium tuberculosis, many people get infected. For example, in India, even I may be infected by Mycobacterium tuberculosis, but I am not producing the disease. Because my immune system taking control of this bacteria. My immune system is taking control of this bacteria. If the immune system goes down, then the bacteria comes up. Okay. So what is the basic test we do is very important in pulmonary tuberculosis or any tuberculosis. It is called Mantoux test. It is called Mantoux test. Okay. What we do in this Mantoux test is we check a immune process called delayed hypersensitivity. Okay, in the next semester they will talk more about this. So now just to understand the name, it is called, we check a process which is seen in the Mycobacterium tuberculosis. That process is called delayed hypersensitivity. So how we check? We we make some product from Mycobacterium tuberculosis. That product is called purified protein derivative. We call it as PPD, purified protein derivative of Mycobacterium tuberculosis. We take, it is available in the pharmacy. We take that and we inject in the person's skin. We do intracutaneous injection. Okay, we will not put it in the muscle. We put in between the skin and the muscle, intracutaneous injection. After few hours we see, that is after 48 to 72 hours, we see in that area, if they have tuberculosis, we see visible palpable induration. Induration means small swelling. Visible palpable induration. If that is there, it is positive. If that is there, if it is positive. So positive tuberculin test signifies there is T cell mediated immunity towards, T cell means T lymphocyte, T lymphocyte mediated immunity towards mycobacterial antigen. Okay, what it says is there is infection, but it cannot say whether there is disease or not. Okay, you understand the difference between infection and disease? Disease is if it produce signs and symptoms. If it produce signs and symptoms, that is disease. Infection means the person may have the mycobacterium, but they are not producing the disease. So this test tells us whether they have mycobacterium or not. Okay, it will not tell you whether they have disease or not. The disease is done by the clinical examination and the other investigations. So this investigation is done to know whether the patient having mycobacterial infection or not. You understand? There is a big difference between infection and disease. Okay. So false negative reaction, that is the person may have mycobacterium, but the result is coming negative. You understand? The person is having mycobacterium. If the result is coming negative, it is called false negative. Understand? So it can be seen in some viral infection or Hodgkin's lymphoma or immune suppression. At least three you should know. Immune suppression. If they have these three conditions, the patient may have infection. Okay, the patient is having infection, but the test is coming negative. So false positive reaction means the person is not having infection, but the test is coming positive. Understand? So in the inshallah I will summarize this slide. So here it can come if the person have some atypical mycobacterium, or they did vaccine for mycobacterium. If they have been vaccinated, I think we all vaccinated. Okay, everybody they put this vaccine in the child. So when you are infant, they put this vaccine. This is called BCG vaccine. Okay, Bacillus calmette guerin vaccine. Okay, so if I ask what is the vaccine they put for mycobacterium infection, you should write BCG vaccine. Okay, Bacillus calmette guerin vaccine. So let me summarize this slide. See, I told these two slides, just I will summarize. Okay, so I told we are discussing about a infectious condition called tuberculosis, right? Tuberculosis. Commonly we doctors call it as a TB infection. See, this infection is commonly comes in the lung. So we call it is pulmonary tuberculosis. Okay, we call it as pulmonary tuberculosis. It is by which bacteria? Mycobacterium tuberculosis. This is the name of the bacteria. Okay, So another type of infection which comes in the tuberculosis is oropharyngeal and intestinal. So intestinal tuberculosis. It is produced by which bacteria? Mycobacterium bovis. Easy to remember, it is from the cow. It is Mycobacterium bovis. Okay, now see, this bacteria is commonly seen in the tropical countries, or all the tropical countries are developing countries like India, Pakistan, Malaysia, any African countries. These are the countries this is very commonly seen, and it is not seen much in the developed countries. Okay, so in the developed countries now it became a problem because of increase in HIV. Increase in HIV, because HIV causes immunosuppression, because HIV damage the T lymphocyte. HIV damage the T lymphocyte. You all know in the last session T lymphocyte is the one helps the macrophage to kill the mycobacterium, right? T lymphocyte is the one secretes interferon gamma. So if there is no T lymphocyte, what happens? There cannot be interferon gamma. They cannot kill the mycobacterium. Understand? So that's why if there is HIV, the T lymphocyte is less, so they get TB infection. They get tuberculosis infection. You understand? So that's why in the developed country now it becomes a big problem. Understand? So now there is in the developing countries they may have an infection but they will not produce disease. So infection is different from disease. Infection is different from disease. For example, this is a person, you can take Abdullah. Okay, he is got TB infection. Okay, and his immunity is good. Okay, so he will not produce no disease. You understand? So he is infected but he is not having disease. He is infected but he is not having disease. Okay, if Abdullah's immunity goes down, then he will produce disease. Okay, he will produce disease, so that damage the lung and he will produce signs and symptoms related to the disease. Okay, now if you check the Abdullah for TB infection, we check by a test called Mantoux test. What we do is, there are commercially available antigen of mycobacterium, that is called PPD, purified protein derivative. It is not a living bacteria, it is a purified protein derivative of mycobacterium. Purified protein derivative of mycobacterium. So what we do is, in Abdullah's hand we inject it. We inject and we see after 48 to 72 hours if there is any change, that is called induration. Small swelling, reddish swelling, if we see, then Abdullah is infected with TB, positive for TB. Understand? I told he is infected, the result is coming positive. Okay, it is true positive. It is true positive. Okay, now Abdullah is infected, the test is coming negative. The test is coming negative. It is false negative. You understand? It is because Abdullah is infected, but the test is coming negative. It is false negative. It happens if the person is having any other disease, that is, if he has viral infection, or he may have some immune suppression, less immunity, and or he has some lymphoma, blood cancers. Okay, so in those conditions he may be infected, but the test is coming negative. The test is coming negative. Okay, for example, he may produce disease also. Okay, he may have TB disease, but if you do the Mantoux test, he may be having negative. Mantoux test may be negative. That is called false negative. That is called false negative. Understand? So another thing is, Abdullah may not have TB itself. He will not have TB itself, but the test is coming positive. The test is coming positive. It is false positive. It is false positive. This can be seen if Abdullah in his child is vaccinated. If he is vaccinated, BCG vaccine. If Abdullah had BCG vaccine, he might have test positive. He might have test positive. It is false positive. It is false positive. Okay. So this is the summary of the slides which we discussed. You all understand this? Okay. So if you don't understand, just go back and see the video. You will understand it. I think I did very slowly here. Okay. So once again, just I summarize it because it's a tuberculosis infection, and there are two patterns I am discussing. There are many patterns. I am discussing only two. One is pulmonary tuberculosis, oropharyngeal, intestinal tuberculosis. Pulmonary tuberculosis is produced by Mycobacterium tuberculosis. Intestinal and oropharyngeal is produced by Mycobacterium bovis. Okay. Now, when this, which part of the countries it is common, it is related to the pathogenesis. If in the tropical countries, if the person has good immune system, like India, Pakistan, South Africa, if they have very good immune system and they may have infection, they will not produce the disease because immune system controls it. Immune system controls it. In Western countries, it becoming a big problem now because they have increased HIV patients. So HIV patients, there will be less T lymphocyte. You all know T lymphocyte is needed to kill the tuberculosis. So now they have lot of tuberculosis. Now they have lot of tuberculosis. So to check whether the person is infected or not, we do a test called Mantoux test. So in the Mantoux test, we put protein derivative of Mycobacterium, purified protein derivative of Mycobacterium in the cutaneous part of the body, and we check what reaction it shows. If it shows in 48 to 72 hours a visible induration, okay, visible swelling, reddish swelling, and that is positive. That is positive, which means the person is infected. We don't know whether he has disease or not. He is infected. So in some condition, he may be infected. He is infected. The test is negative. That is false negative. That is false negative, and false negative be seen in these conditions. If the person is having viral infection, if the person is having lymphomas, if the person immunity is less, if the person's immunity is less, then this is about false negative. Or the person may not have infection itself. He may not have TB infection itself, but the test is coming positive. The test is coming positive. So this is false positive. This is false positive seen in, at least you remember one. In, if the person is vaccinated, he may have false positive result. He may have false positive result. Okay. So this is the summary of the previous slides which we discussed. Let us go to the other slides. So now, pulmonary tuberculosis pathogenesis. Actually, this we already discussed in the chronic inflammation. Just it's a summary. You can take it like a summary. So I told this Mycobacterium enters the lung, right? In the lung we have alveolar macrophage. In the lung we have alveolar macrophage. So this say forget about this. What I am telling, if you remember, that is enough. So the mycobacterium takes it inside, okay, and the mycobacterium they cannot kill the mycobacterium, right? They cannot kill the mycobacterium. So the mycobacterium grows inside the macrophage. The mycobacterium grows inside the macrophage. This happens within 3 weeks. This happens within 3 weeks. After 3 weeks, this mycobacterium enters from the lung to other parts of the body. Okay, it goes to the lymph node after 3 weeks, and they communicate with the T cell through interleukin 12. They communicate with the T cell, CD4 T cell, to interleukin 12, and the T cell releases interferon gamma. T cells releases interferon gamma. Then they activate the macrophage to kill the mycobacterium, and they form the granuloma. So this all we already discussed. I think this will be very clear to you. Now let us see what I given in this slide. So pathogenesis in less than 3 weeks. We divide them as a less than 3 weeks, more than 3 weeks. So mycobacterium tuberculosis enters the macrophage, and they replicate, they grow in the macrophage, because the mycobacterium, this is very very important, the mycobacterium, come on, block the fusion of phagosome and lysosome. So now the bacteria is coolly, now macrophage is like a guest house for them. So they keep on growing inside and they go to multiple sites. Mycobacterium, now it is entering the lymph node. Okay, you all know lymph node. They enters the lymph node. In the lymph node we have T cells. T cells means T lymphocytes. T lymphocyte. Then the T lymphocyte stimulates, and they by the IL-12, and they become activated, and then they become activated and they release interferon gamma, and this interferon gamma again activates the macrophage. Then the activated macrophage again releases the IL-12. The cycle continues. Now, why interferon gamma? Very very important, because if there is no interferon gamma, the whole process gets stopped. Tell me, interferon gamma is secreted by which cell? Come on. Interferon gamma is secreted by which cell? Okay, T lymphocyte, mashallah. So the T lymphocyte secretes interferon gamma. If the anything happens to the T cell, do you think interferon gamma can come? It will be reduced. So this is the mechanism happens in HIV. The HIV virus infect the T lymphocyte and they destroy the T lymphocyte. Automatically the interferon gamma is reduced. Understand? That's why HIV patient is prone for many infections. Okay, now why interferon gamma is important? Because they do 3 things. 2 things you guys know. One is they make the phagolysosome, fusion of phagosome and the lysosome. Okay, now this is phagosome, this is lysosome. Okay, now these two will fuse. When these two fuse, they will try to kill the mycobacterium, but they need another substance to kill the mycobacterium, that is called nitric oxide. That is synthesized due to the stimulation of interferon gamma. Understand? So now they make more, they also recruit macrophage. You all know, right? They go to the blood vessel, they recruit the monocyte, they make macrophage, and they form giant cell. All macrophage come, and some macrophage fuse and they form giant cell. So this is the necessity of interferon gamma. If there is no interferon gamma, the whole mechanism stopped. If this stops, the TB coolly grow and it spreads all over the body. And it kills the patient. Okay, now we classify the pulmonary tuberculosis into 3 types. primary tuberculosis, secondary tuberculosis, and tertiary tuberculosis. Very easy, okay, because it is very important. So primary tuberculosis means the person getting infected first time. The person getting infected first time, that is unexposed person getting infected. Secondary tuberculosis is the previously infected person gets reactivated, understand, or reinfection. It can get again infected or the infection gets reactivated. I will tell you as a story so you will understand. Let us draw the lung. See, so this is the right lung and the left lung, okay, and this is trachea, bronchus, okay. Now if the person is an unexposed person, okay, he is getting tuberculosis, okay, and the tuberculosis usually go into the area of junction between the upper lobe and the lower lobe. You all know right side has three lobes, okay, one is upper, middle, lower, right? So but it goes to the area of junction between the upper lobe and the lower lobe, that is lower part of the upper lobe, upper part of the lower lobe. You all understand? Lower part of the upper lobe, upper part of the lower lobe, and near to the pleura. You all know there is a pleura, right? And near to the pleura they go here and they produce nodule. They produce nodule there, okay, some small swelling there, okay. This is just below the pleura, subpleural nodule, but location is just lower to the upper lobe, upper to the lower lobe. So this is called gone focus. This is called gone focus, okay. So now it is less than 3 weeks, okay. Now the bacteria is growing, right, in the macrophage. Now they can enter the lymphatics and they go to the corresponding lymph node. Here the lymph node, it goes to the corresponding lymph node, understand. If you see two nodule, one is in the hilar lymph node. This is the hilum, right? You know hilum? Hilum is the entry of bronchi, blood vessels to the lung. Okay, that's like a gateway. So in the hilum there is a lymph node swelling and there is a nodule, subpleural nodule. If you see these two, this is called gone complex. This is called gone complex. You will be seeing more than 3 weeks. See, I am relating the morphology with pathogenesis. It is more than 3 weeks. Okay. So if you see in a person X-ray, there is one nodule in the lung, subpleural nodule, just below the upper lobe, above the lower lobe. It is gone focus. It is gone focus. And if you see the corresponding nodule in the hilum of the right side, then it is gone complex. Then it is gone complex. So if you see these two, it is primary tuberculosis. It is primary tuberculosis. It is called primary tuberculosis. Understand? So now the person immunity is very good. So he controls it and it destroys it. He controls it, he destroys the mycobacterium, and even though he destroys the mycobacterium, some mycobacterium will be living, but they will not be active. They will not be active. Understand? So this is the stage of primary tuberculosis. This is the stage of primary tuberculosis. If you see the same thing in the children, it is called primary complex. It is called primary complex. If it is seen in the adult, it is called primary tuberculosis. It is called primary tuberculosis. Okay, now once again just I summarize it. See, the person is unexposed person. He is getting the TB bacteria first time, Mycobacterium tuberculosis first time. It goes to the lung, and it goes to the which part of the lung? Lower to the upper lobe, upper to the lower lobe, near to the pleura, near to the pleura. That is subpleural nodule. That is subpleural nodule. In X-ray, if you see that nodule, that is called gone focus, which happens within less than 3 weeks. Now the bacteria is growing in the macrophage. Then it enters the lymph node. Then it enters the lymph node. Corresponding lymph node is right hilar node. Right hilar node. And that is also producing nodule. Then this 2 is seen. It is called gone complex. It is called gone complex. If you see this 2 condition, any gone focus or gone complex, it is primary tuberculosis. It is primary tuberculosis. You understand? So this primary tuberculosis, the person has a good immune system, good T lymphocyte, good interferon gamma, it settles. It settles. Now, if it is seen in the same condition seen in the children, it is called primary complex. It is called primary complex. Now, the person immunity is going down. In this person, the immunity is going down. Okay, the immunity is going down. Then what happens? This bacteria, now it is, before that in the primary tuberculosis, it is settled, right? It is our immune system killed and solved it. Okay, because it is a chronic inflammation, they will end up with fibrosis. They will end up with fibrosis. So it is a fibrotic nodule. It is a fibrotic nodule. And in the X-ray, if you see, because of calcification, it is called Ranke's complex. You should know this because these are the terminologies we use. Okay, it is called Ranke's complex. In X-ray, if you see, because of calcification, it is a dystrophic calcification because calcium deposits in the dead tissue. So it is a dystrophic calcification. You see, it is a Ranke's complex. You see, it is a Ranke. It is called as Ranke's complex. Okay, now the person immunity is good. This all happened. Now the immunity goes down. Now the person's immunity goes down. Okay, the person immunity goes down. Right, now this bacteria again comes. The bacteria again comes, and it can go, actually it goes to the apex of the lung. This is called apex. It goes to the apex of the lung and it produces big lesion. It produces big lesion because there is no immunity, enough immunity. It produces big lesion. This is called apical lesion. This is called apical lesion. Lesion means some change. Okay, it is called apical lesion. Okay, now you are taking an X-ray and the person is showing some change in the apex. Okay, some hole in the apex. What you say? It is a secondary tuberculosis. It is a secondary tuberculosis. So there is, the person is already infected, because of less immunity, reactivated. It is reactivated. The infection is reactivated. It is produce apical lesion. It is secondary tuberculosis. This is the stage the patient is highly infectious. The patient is highly infectious because they keep on coughing. Each time when they cough, all mycobacterium comes out. All mycobacterium comes out and they bring some part of the lung outside. Actually, they bring the lung itself outside and it comes with a sputum. You all know sputum? Yes or no? In Arabic, what Bashir? Huh? Belgam, huh? Okay, it is called sputum. They bring blood mixed sputum. Hemoptysis. It is called hemoptysis. These are medical terminologies. Okay, it is called hemoptysis. They bring the blood mixed sputum. In that they bring the part of the lung outside. They bring the part of the lung outside. This lung will become like a really, it becomes like a hole in the lung. It is called apical cavity. It is called apical cavity. So when you see a apical lesion, apical cavity in the X-ray, it is a secondary tuberculosis and it is highly infectious state. The person brings the blood, brings the sputum, keep on coughing, they take the bacteria out always, and it is very dangerous stage. It is very dangerous stage for the people surrounding him. Okay, so it is secondary tuberculosis. It is secondary tuberculosis. Okay, again the person immunity is going very severely down. It is going very severely down. What happens? The mycobacterium spreads in the blood. It goes in the blood. The mycobacterium goes in the blood to all over the body. All over the body. They produce seed, like you all know seed. Okay, now the mycobacterium immunity goes down, and this is the lung, and you all know now it is apical lesion, right? It is secondary tuberculosis. Now the mycobacterium spreads in the blood. When they spread in the blood, they again come to the lung also, and they produce small seed like deposit. You all know seed? Any seed? Okay, seed like deposit. This small 1 to 2 millimeter size seed like deposit, it is called tertiary tuberculosis. It is called tertiary tuberculosis, and it is dangerous stage. It is the dangerous stage, and it is commonly seen in the HIV patients. It is commonly seen in the HIV patient or cancer patient, immunosuppressed patient, renal transplant patient. Those patients are severely diseased patients, diabetic patients. Those patients you can expect tertiary tuberculosis. You can expect tertiary tuberculosis. You want to summarize once again? Okay, I'll ask question. Okay. Now the person is unexposed. Which area the infection goes? Anyone can tell? Right or left? Any area it goes, but it goes to the lower part of the upper lobe, upper part of the lower lobe, and near to the pleura. Near to the pleura. That is subpleural nodule. And that happens less than 3 weeks. Okay, if you see only subpleural nodule, it is gone focus. It is gone focus. After 3 weeks, it enters the lymph node and it produces corresponding hilar lymphadenopathy, hilar lymph node swelling. It is, if you see these two, what is called gone complex. It is called gone complex, and this is primary tuberculosis. This is primary tuberculosis. Now the person immunity goes down. Now the next stage is the person immunity goes down, and there is gone focus, gone complex, and the person immunity goes down. Then what happens? The bacteria travels to the apex and they produce massive lesion there. Okay, this is secondary tuberculosis. This is infectious stage. The person will produce all signs and symptoms. It is easy to diagnose. They produce all signs and symptoms and they bring the bacteria out. So this stage we take the patient's sputum and we do special test in the lab. Okay, we culture the bacteria, we grow the TB. Understand? So that is called TB culture. That is called TB culture, and we see, we do special staining, that is called acid. You should know this. That is called acid fast staining. So this is the stain we do and we see in the microscope. You can see very good bacteria. Okay, so this is highly infectious stage, and the person is called secondary tuberculosis. So if you have this, it is primary tuberculosis. And the person, his immunity is further going down, what happens? It can go in the blood, and then it can produce small seed like deposit in all the organ. It can produce seed like deposit in the lung, in the liver, in the spleen, even in the brain. Okay, even in the brain. Okay, so this is tertiary tuberculosis. That is tertiary tuberculosis. Okay, let's see the slide. Okay, primary tuberculosis is seen in the unexposed person, and secondary tuberculosis may be seen in the previously infected person, and it is causes reactivation due to reactivation or reinfection. It usually involves the apex of the upper lobe of one or both lungs and form cavity. They produce apical cavity. So malaise means tiredness, anorexia means they will not feel hunger, and weight loss and fever and night sweats. These are the classical 5 symptoms of tuberculosis. Classical 5 symptoms of tuberculosis. They produce sputum and they bring blood in the sputum, that is called hemoptysis. And tertiary tuberculosis, if the mycobacterium organism enters the circulation, they go to multiple organ. That is tertiary tuberculosis. So primary tuberculosis in children are called as primary complex, and primary complex, it can be do 4 things. Once there is a infection, it can become calcified, calcified, or if the immunity goes down, it can progress in the lung. Infection can progress in the lung. If immunity is severely affected, it can spread to the other lung. Sometimes the infection becomes latent. Latent means it will be very subtle, you cannot identify it. It will be keep on reactivating the primary lesion. These are the 4 things happens in the primary complex. Now coming to the morphology. So in primary tuberculosis, I told there will be involvement of lower part of the upper lobe or the upper part of the lower lobe close to the pleura. You can see here nodule, right? In the lung, and here there is also nodule. This is gone focus or complex? Gone complex, because you see node as well as lung lesion. It is a gone complex. So there will be formation of gone focus or gone complex. If there is fibrosis in the gone complex, it is called Ranke's complex in radiology. In X-ray we call it as Ranke's complex. They produce caseating granulomatous inflammation as well as sometimes non-caseating. So now coming to the secondary tuberculosis, the lesion seen in the apex of the lung. You see there is hole in the lung. Okay, here the person brings out all the parts of the lung in the sputum, and it forms cavitation, and it produces caseating granulomatous inflammation. Remember, in primary tuberculosis you can see non-caseating granulomatous inflammation, whereas in secondary tuberculosis you always, very important point, you always see caseating granulomatous inflammation, and it even the mycobacterium can erode the bronchi and the blood vessels, and the patient may take complete blood out. Okay, so this all the things can happen, and they produce hemoptysis. Hemoptysis is blood mixed sputum. Miliary tuberculosis, it can be local. Miliary means tertiary tuberculosis. Miliary means seed, millet seed. Okay, so miliary means millet seeds. So it can be systemic miliary tuberculosis. Local miliary tuberculosis means within the lung they deposit like a small 2 millimeter size deposits, and it is called consolidation. Consolidation means that area lung becomes solid. And it is called local miliary tuberculosis. Systemic miliary means it goes to the other organ, like it is the spleen. Go to the liver, spleen, or any part of the organ they can go, even kidney, brain, any area they can go. They produce this kind of seed like deposit, small white color to yellowish color seed like deposits. So now coming to the isolated tuberculosis, this tuberculosis coming not in the lung, directly coming in the other organs. It can come directly in the meninges. You all know meninges, the covering of the brain. It can come in the meninges. It is called tuberculous meningitis. It can come in the adrenal gland, and it can come in the kidney, and it can come in the bone. Okay. So when we call isolated tuberculosis, for example, the person is having tuberculosis in the mandible, his lung will not have any lesion. Lung is free of tuberculosis. Lung is normal. Then we suspect isolated tuberculosis. You understand the word isolated, which means it is not occurring in the lung. It is occurring directly in the other organs. That is called isolated tuberculosis. If it comes in the vertebra, spine, it is called pot disease. It is called pot disease. Okay. And you all know Mycobacterium bovis can affect the intestine. It is called intestinal tuberculosis because of drinking the contaminated unpasteurized milk. Okay. Or sometimes it can come, the person having lung tuberculosis, pulmonary tuberculosis, they bring the sputum and they swallow it, especially children. They swallow it. When they swallow it, that bacteria goes to the intestine and they produce pulmonary disease, producing intestinal tuberculosis. So intestinal tuberculosis come in two ways. One is drinking the milk or drinking the sputum. Okay. What is the time? Okay, you all feel overburdened, or shall I continue? Shall I continue, or shall I stop here? Stop. Okay.